Welcome to this meeting of the Healthcare and Wellbeing Scrutiny Committee being held on Wednesday, the 11th of February 2026. For those present in the meeting room, if the fire alarm sounds, please leave the building by the nearest exit and make your way to the fire assembly point in the car park. The agenda papers and other relevant information for this meeting are available for public viewing on the Herefordshire Council website. The Council is streaming this meeting live on the Herefordshire Council YouTube channel and is making a recording. Others are permitted to film, photograph and record public meetings, providing it does not disrupt the business of the meeting. If there are any members of the public present who do not wish to be filmed or photographed, please raise your hand now and no filming will take place. Actually, there's nobody in the room, so just in case they do come, anybody does come. For participants in the room, please raise your hand to indicate that you wish to contribute. When invited to speak, press the button on the right-hand side of the microphone unit and speak directly towards the microphone. Please remember to turn your microphone off once you've finished speaking. Please ensure that mobile phones, laptops and other devices are turned to silent. We have no remote attendances today. So that part doesn't need to be said. Okay, so item 1 on the agenda is apologies for absence. There have been no apologies for absence and therefore there are no substitutes, which is item number 2. It's really good to see everybody here, thank you. Item 3 is declarations of interest. Do any members wish to declare any interest in the agenda item? No, nobody. Okay, item 4 is the minutes. The minutes document on the meeting held on the 24th of November 2025 are included in the agenda pack, pages 11 to 14. No matters of accuracy have been notified to the monitoring officer. Are you content that I sign the minutes as an accurate record?
Aye.
Yep, thank you very much. So items 5 and 6 are questions from members of the public and questions from members of the council, and we have not received any questions from either of those groups. So right on to item 7, which is Herefordshire and Worcestershire Health and Care NHS Trust Strategy. So in the room we have 2 representatives of that trust, and they will introduce themselves when they start to speak. So this item is to enable the committee to scrutinise the Trust's strategy for 2025 to 30, particularly in light of the last CQC findings. Our focus today is on how the strategy addresses identified concerns, how improvements will be delivered, and how progress will be measured and reported. I'd like to remind colleagues and trust representatives that the role of this committee is to constructively challenge on behalf of local residents to ensure that services are safe, effective and sustainable. We did receive yesterday, and it was, Sue, that we requested this on Monday, which didn't give you much time to produce any action plan or further update. So I'm going to apologise, I haven't had time to look at that in detail. So we will go through it with you if that's okay. Okay, so we'll hand over to Sue Harris and she will introduce herself and also explain the history of why you're here and what we're doing.
Okay, thank you very much. So, yes, for those who haven't met before, Sue Harris. I'm now the Director of Strategy, People and Culture, and as I move on through giving you a bit of an update, I'll exchange that my role has changed slightly since I last came to see you. And yes, I also thankfully that we were able to have the opportunity to put more detail in. The NHS planning machine is in earnest at the moment, and we're actually submitting our final plan on the 12th of February. So the document you had sent round yesterday gives you more detail around what some of those key metrics are and what some of those areas of concern are. And I'm going to ask David quickly to introduce himself, but he's going to walk through some of the more operational elements as we move on through our update.
Thanks, Sue, and good morning. I'm David Thomas. I'm the Associate Director for Primary Care and Community Mental Health in the Health and Care Trust. And I do, as an element of my role, also have a particular leadership responsibility for the services that we deliver in Herefordshire. I'm the key point of contact at Associate Director level.
Okay, so it's probably worth just reminding members that some of this update is directly linked to the CQC improvement plan that we've come and spoken to you about before. You will notice now much of what we picked up in the improvement plan and much of that work was around culture has now been embedded into our strategy. So it was just to provide some assurance that we haven't lost sight of those actions. A lot of them are now complete, but we want to see them embedded in our business as usual processes. So very much the forefront of the strategic intent that I'm going to walk you through this morning. Also, just to mention that we've had some significant changes to our board since I last came to see you. Very sadly, we lost our chairman, Mark Yates, last year, and at the same time, we've got an incoming new chief executive, Ellen Rawls. So that's been quite turbulent. So we also wanted to set out strategic intent because we felt it was important across the organisation that there was some stability, people could see the leadership and see our commitment, especially to the journey around culture. We also moved to have an executive restructure over the summer of last year, and we've now got an executive team of 6 with Ellen as the chief executive. My role has now moved to still have strategy and partnerships, but I've also now got people and culture. So that's a bigger portfolio for me. And that's equally true of my colleagues as well. So all of that work's been happening to try and make sure we've got a really cohesive collegiate team to steer the ship where we need to go over the next 5 years. So the strategy you have that we've been sending round, I've got in front of me, the sort of one of our glossier versions, is really setting out some of the journey we've been on and then some of the must-dos. I suppose it's important to emphasise this is more about how we do things and how we want the organisation to feel. The what is coming through the NHS annual planning cycle. A lot of that, when David outlines it, is nationally stated. There's certain KPIs that we have to meet. There are certain trajectories we have to deliver against. The problem with having a strategy, and I've done a number of these now, I've been in the trust since 2012, if we go too far past 3 to 5 years, especially in this climate, these documents very quickly become out of date. So I want to make no bones for the fact the detail's not in this document, so absolutely great that we get the chance to talk that through. But I do think it's really important as well to notice that a lot of this is about how do we make sure our staff really understand the organisational journey we've been on, where we're going next. And in particular, we went round with part of our national staff survey asking, do you recognise some of the strategy? How socialised is it? We've had a really good take-up of people saying, I know there's a new trust strategy, I could broadly tell you the content. And then we're going to be doing more workshops and more socialising, because this is absolutely about connecting people into staff experience, the whole piece around living within our means, and then the work we need to do around neighbourhood health, and then the step change around digital. So when you walk yourself through the document, the things that might jump out to you, the values of the organisation were co-produced in 2012. When you talk to staff, they still resonate, so those remain the same. So that's the CARES values, that's courageous, empowering, responsive, done the wrong way around, sorry. Courageous, ambitious, responsive, empowering and supportive. People felt that the vision needed to be updated really to give us something that was more akin to where we want to go in creating healthy communities, so that's a shift. And the strategic objectives, whilst many remain the same in terms of their intent, they've been co-produced with our staff, reflecting a language that people said they resonated with them. So that was around value and respect, making sure that we've got that piece around our use of resources, the partnerships, the innovation and digital, and then making sure all of that gives us an opportunity to provide high quality care through the strong foundations of the organisation. So we've then set out in the document, what's this mean? What would it mean to our staff, what will it mean most importantly to the patients and the communities that we serve, and setting out some high-level ambitions around what good would look like. The actual detail then I'll drop over into David to give you a sense of what that looks like in the next year or two. But from April 2026 will be when we start reporting on the strategy. It's quite difficult to start reporting at the mid-year because you lose your whole annual report progress because you're not able to track that. So we have deliberately socialised the strategy, we've launched the strategy, but the reporting starts in April. Very much then embedding it in our decision making, so people will be able to track very publicly and actually within our committee structures what we're actually deciding on and how that's contributing to the trust strategy. And all of this really comes back to me in terms of how do we then make sure that some of the bits where we've come to you before and said staff felt that they couldn't escalate, raise concerns. We've done so much work in that space now, and we're already seeing the metrics change for us around that from our staff and the feedback they give us. But actually, they wanted to see how the governance really helped them do their best job at work. So a lot of this strategy is speaking to that space to make sure that we really enhance that staff experience and that people feel valued and respected. So those were the headlines from the kind of the main document. And David, can I pass you to just walk through the document that you got sent yesterday?
Sure, thanks, Sue, and good morning again. I think what I was going to do was just draw out, if we're referring to the summary document that was sent through, I'm going to refer initially to the key areas, which is the table up front, which is a brief summation of some of the really headline.
Sorry, just a moment. If it's okay with you, I'll just put this on the screen as well, just for ease of use, if that's all right. It's okay, carry on.
That'd be helpful, thank you. And teasing out in particular those that pertain to focus on mental health delivery, because of course that's the business with which we're concerned from a Herefordshire perspective specifically. If I start with, therefore, delivery of access and recovery standards within psychological therapies, that bears particularly on two service delivery elements. One of those is talking therapies, which some may know of old or have encountered in the past as IAP services, not too long ago rebranded as talking therapies nationally. And the other one is IPS, which is individual placement services. That's the specific employment support offer that sits within or in the context of the neighbourhood mental health team, our core community mental health offer. Maybe worth adding that in a Herefordshire context, that IPS service is actually delivered through a subcontract with a third sector provider, Landau. If I speak to talking therapies first, you can see there from the table that we're working towards an ambitious expansion by 2028-29, working up to about 10,000 completed treatments. And a completed treatment in this context is a service user who's completed a course of 2 or more treatments. Often it's considerably more than that, but the sort of the minimum is 2 or more treatments. And that's recognising that in some cases some people will come into the service who then actually it's not the right service for them for a whole host of either personal or clinical reasons, and they may go on to other services thereafter. So 10,000 completed treatments is the goal. To contextualise that, we're predicting at the end of this year we will likely alight somewhere around about 7,000 completed treatments across the 2 counties. So that is a very significant expansion, but it's maybe worth adding that a lot of the expansion in workforce terms that will ultimately deliver that completed treatments goal at the end of that 3-year period is effectively already in the pipeline. So the funding is there, the funding is agreed, the workforce is there. We have in Talking Therapies a very specific model where we bring trainees into the service and train them in the service in cooperation with various universities and university courses. What that means in effect is you always have a lag between the initial investment and the initial recruitment activity and the final full delivery of a service, which then translates to, yes, completed treatments, actually patient service users going through the service. We have been, Talking Therapies Herefordshire and Worcestershire has actually been the most rapidly expanding service nationally over the last year or two, as I understand it. We've grown the workforce very considerably in that time, recognising that actually we were behind the curve in expansion terms, and the vast majority of that workforce to deliver ultimately that 10,000 completed treatments is already in place, even if they are at the moment still in training and therefore not delivering to full effect. So we are at the moment predicting that we will deliver that 10,000 completed treatments at the end of this time frame, and next year is when we expect to catch up with our planned trajectory for that. So we're expecting, I think, about 8,500 completed treatments next year. Again, just to contextualise. IPS is a considerably smaller service. The target for Herefordshire specifically as a subset of the overall target this year, I think is somewhere in the order of 200 accessing the service, just to give you an idea of scale. There will be a slight shortfall on that this year, and that is fairly directly as a result of delays in the initial agreement of funding contracting through the ICB to us, to the third party, and effectively the delivery catching up with itself. But again, we're predicting that we will deliver on that trajectory in the sort of the near to medium term. And again, the funding and the expansion, by and large, is there to do that. So that's a positive position. Skipping over the next one, which is an urgent care physical health, largely physical health preoccupation. The next three items in the table there are all quite closely connected.
Can I just ask you something before we move on? Just going back to these numbers, Herefordshire possibly 200, and the number you've got is 696. So we're only 1/3 of that business. Is that right? And has that increased from the year before? Because looking at the projections, then we're going up. Not significantly, really, but still. And also, have you planned for any trained staff leaving?
Thank you, Chair. Yes, so that 696 is a very slight increase on this year's total. So I said the Herefordshire element is about 200. I'm sorry, I don't have that precise figure off the top of my head, but I do know that the Herefordshire and Worcestershire combined total for this year is 683. So next year's target is a marginal increase on this year's. That's actually a revision. It was slightly higher previously. Yes, the target this year is an increase on last year, which is precisely why we did have an increase in funding, an increase in staffing, but there's been that slight lag. That is why we're slightly behind, which is regrettable, but it is clear that it's associated with those delays. And yes, the split is roughly a third, 2/3, which is roughly commensurate with the sort of the population, the sort of the base, isn't it? I'm sorry, I can't remember whether there was another question in there as well.
It was just to understand if you've got any plan for any trained staff leaving. So
sure.
This is a bit of a volatile area, isn't it? With any health industry, there's always a big turnover of staff. So.
Yes, so there's probably a couple of nuances to that. So firstly, we do have churn within our services, but we've actually got the lowest churn in workforce that we've ever had, at least in the time I've been around these services. And I've been around this specific group of services for, I think, a little over 5 years now. and in that time, the churn has consistently come down and down and down and down. I can remember when it was, I think, sort of 18 to 20%. Our churn now is well south of 10%. So the churn being, year on year, the percentage of posts that will turn over, where it will change. The other slight wrinkle here, of course, is that the question of churn with respect to IPS in Herefordshire is not so much a direct operational workforce question, it's a contracting question. So, as I said, this service is delivered through a subcontract with Landau. So the issue for us really is, we contract with Landau, we have a set of expectations and outputs, and Landau agree to meet those. By and large, when we do give them the resources to do the job, what we find is they very effectively deliver on that. So, yes, it's always a consideration or a possible fact we have to tarry with. But by and large, Landau have a good record, and we'd be confident that the contract would do the job.
Thank you, David. Councillor Tillett just wanted
Just while we've interrupted your flow, David, and I'm sure my colleagues might be thinking this as well. Some of these target figures are so very specific. How do you get to 10,052? Or a target of 696 increasing to 768 to 807? Have you got people lined up? I mean, or is this purely a sort of statistical juggling act?
I think probably the latter is true. A lot of the time, this is a national aggregated figure that is then just allocated out to different systems, and that's how you end up with some of these percentages. But you are right, very specific. Now, things like talking therapy, that's a high volume service, a lot of people coming through. So, those trajectories we know about, and you can get as close to them. IPS is a little more challenging, isn't it? Because it's really small numbers. These are really, really poorly folk, often have been with us in inpatient settings, and we're now supporting to try and get them back into the workplace. So a lot of really intensive work. And we need to make sure we're getting the right people into those services, and those where some of those smaller numbers become trickier. But yes, then they're not lined up. And it's a disaggregation, probably at a macro national level, down into system spaces.
It just strikes me that obviously, with such specific targets, it's almost setting you up to fail, because even if you fall a few short, then the headline figure is we failed to meet the target. But it's probably outside your control. But it does look a bit bizarre on paper.
Sorry, David, we've started something now. Councillor Davies would like to ask something.
Thank you, Chair. I just want, with the increasing numbers forecasted, do we envisage a plateau at any time and numbers start to reduce, or is it anticipated that it's going to continue to rise? Are we going to have, better support within the communities, therefore there's going to be less of a requirement for talking therapies? Just a question.
Thank you, Councillor. I will just say, first of all, what we've been talking about, I have also checked the Herefordshire target for this year for IPS is 217. So when I said it was about 200, it's 217. I think the answer slightly is that's a bit of a crystal ball question. But maybe it's worth saying that these are services, particularly talking therapies, that have expanded very considerably and very rapidly in recent years. Logically, there is a ceiling for that. To some extent, that ceiling is probably closely related to the overall demography. So if we expect the overall population to plateau, or even potentially in some places to decline, then one can anticipate that ultimately the trajectory for these services will follow that. But precisely where those two graphs cross or meet, that's a little bit difficult to say. I mean, if you're asking what my instinct is, it probably is that we have we have done the meat of the expansion for talking therapies in particular, because it has expanded very considerably. But precisely, at what point it stops ticking up altogether, or maybe even starts to tick down, I'm honestly, I couldn't say. There's probably someone in the Treasury who could tell us.
Thank you. Do you want to carry on now? I don't think there's anything else. Yeah, sorry.
Thank you, Chair. So, and I've lost my place now, but I think on the table we were going to length of stay now. So there are three closely interrelated areas of focus here, which relate to length of stay and use of our mental health bed base. I'm probably going to take them in reverse, actually, in so far as I'm going to skip to the inappropriate out of area placements first, because in many ways that's the lead indicator on this set of measures, or on this group of areas of focus. So what we mean by inappropriate out of area placements is essentially where we have a patient who we recognise and our social work colleagues also, share the view that this is someone who needs to be admitted to an adult mental health bed, typically under some section of the relevant mental health legislation. But we cannot provide, at that moment in time, and with the necessary level of urgency and responsiveness, we cannot provide that bed in one of our own facilities in Herefordshire, or at the outside edge in Worcestershire. And therefore we have to go out of area, literally out of area, and seek that capacity elsewhere for all sorts of fairly obvious reasons. That's really not what we would prefer to be doing or ought to be doing. It is often expensive. Therapeutically speaking, it's often suboptimal, because you are taking that individual further away from their potentially their family context, their social settings. Even if they are admitted, this geographical separation, can be pertinent, not just in their experience of that admission, but also in their experience of discharge and making their way back into that community setting. So for all of these reasons, we really want to be avoiding out of area placements. But regrettably, there have been periods where that's been a line that's been extremely difficult for us to hold, and to a very significant degree, that is closely related to the question of length of stay. Again, fairly self-evidently, if we have a certain number of beds and the patients who are in those beds are staying longer than we might otherwise wish, it's going to be difficult to create the capacity to admit new people to those beds. So this is why out of area placements, inappropriate out of area placements, is a good lead indicator for how we're doing on length of stay to some extent. So we've had a very considerable focus on inappropriate out of area placements over the last year or so. That hasn't been something that I have led on. Gemma Diss, my fellow associate director, who heads up our inpatient services, along with older adult services, adult learning disability, and crisis home treatment services. Gemma Diss has been the operational lead for that work, and it's been very successful. So we have been able to move from a position where we had quite high numbers of inappropriate out of area placements at times, down to this sort of baseline of zero inappropriate out of area placements. So the goal now is to maintain that, and part of maintaining that is to continue the work on length of stay, both for working age adults and older adults. And you can see there are sort of incremental targets for those length of stay, for length of stay for those two domains over the next few years. The older adult targets slightly trail the adult targets because there are some additional complexities, I guess, related to caring for older adults in mental health settings, which just mean that on average length of stay is slightly longer. It's a slightly more challenging proposition. But again,
David, could I just ask
sorry,
you
Jack.
a couple of, no, don't be sorry,
Sure.
please. Could I just ask you a couple of questions on that? So looking at the adults and the reductions in those, how are you going to achieve these reductions? And looking at the older adults, you know, Herefordshire is a demographic of nationally higher than average, over 65s and over 85s. So that's quite significant for your strategy, really. How are you going to look at that one?
Thank you, Sharon, and Sue may want to chip in. But so again, Gemma Diss is the sort of lead for this area, and she would speak much more eloquently and at greater length than I would. But firstly, it's maybe worth saying there has been significant success in this space already over the last year or so. They have delivered length of stay reductions in that time, which has been beating the trend. So you know, length of stay had been a challenge in these settings prior to this work beginning. I think if Gemma were here, she would point probably to at least a couple of sort of big handfuls of stuff that, you know, she's been focused on. Some of it is just about day-to-day systems, processes, rigor. Perhaps it ought not to be the case, but, you know, in my experience in the health service and working elsewhere as well, it often is the case that just bringing additional focus to something at a certain point in time, even if you're working with a really good set of people who are really dedicated to the work that they do, really care about the people they're caring for, it is just possible to engender improvement, because for whatever complicated set of reasons, and it's, you know, it is worth saying that a lot of what our teams are wrestling with, you know, they are very complex issues often, and there can be a whole array of challenges that they're wrestling with. It's easy to lose traction and perhaps to lose focus and to therefore see slippage in performance. So simply by introducing additional rigor, additional focus, you know, a more robust set of systems and processes, it is possible to engender improvement. They have done that. There is one other aspect I would mention, and that is recognising, and this is the case actually in the physical health domain as well, that there is a component of waiting that is really not a health question at all. It does relate to social factors and to you know, social care capacity and input. And this is by no means a criticism. It's not not in the least a sort of a finger pointing exercise. We work extremely collaboratively with social care colleagues, but there are challenges and pressures in that domain as well. They are often not directly at odds with the specifically healthcare pressures, but there are perhaps some tensions or some additional complexities that relate to those slightly differential sort of positions, and these in turn do lead to delays in discharge for patients in mental health beds who are actually, from a healthcare perspective, well enough to depart that setting, but actually the next setting that they need to go to is perhaps not, there's not the capacity there to receive them, or there's not the support in the community from a social care perspective to facilitate that discharge.
Yeah, thank you, David. It's good to hear you say about, you know, partnerships and working collaboratively, because we all speak about this every day in our world. So would there be a chance that Emma could produce something for committee members, so that she can show us how that trajectory has actually been formed? You know, is there a specific formula or whatever? And there was something else and it's gone now, so I'll let you come back in.
I'll come back in and perhaps it'll come back while I'm back in. It's Gemma Dis, and yeah, I'm sure we can. She's actually on holiday at the moment, I happen to know, but we could take that away and bring something back in writing, which will just describe the work that's been done and is being done in support of that. I'm sure, yes.
Could I just add to that as well? It's I think some of the other components have had my programme managers wrapped into this space, so there's really clear action planning sitting under this, so quite a lot of granularity. Real-time reporting has made a significant impact. There's always a bit of a lag around, you know, who's in the beds, who's due to go, how do you manage that? So that grip on process, as David said, is really important. Literally walking through all of those handoffs and making sure you're really thinking, planning on a mission, and also the capacity that sits around it. So for mental health, we have hospital at home or crisis services or home treatment services. They've got to be working with the wards hand in hand to make sure that that person's coming in and out in a timely fashion. And I think the last piece of what David was saying, we certainly in adults, we have a number of outliers who really move that length of stay outside of the average. And a lot of the time it relates to housing. So people at risk of homelessness, especially if, for example, there's any history of arson, they are very, very difficult to find spaces for afterwards. So that's the work we need to do to work through how do we tailor some of these spaces. We've got to try and think through opening up some of the options for some of the people at the moment are either at risk of being homeless, or being made homeless because they've been admitted, or actually that their needs as a tenant has changed and there isn't really anything suitable. So those are the sort of areas where we only need a few individuals, where it's a little bit more complicated and suddenly that length of stay starts to wobble.
And I think that's a really important point, Sue, because we have connections with planning department here, and a good story in my ward was that a social housing provider had a significant site, and they allocated a percentage of that for people with mental health concerns. So it does well. It's working in that community, and it's showing that we are trying to support people, you know, in their own property and getting on with their business and their life. The thing I remembered after, David, it was really about, again, partnerships, and I'm sure you are, but public health in Herefordshire needs to be involved in all of this that you're doing. And also, do you involve Talk Community? Because we're looking at the big neighbourhood health agenda over the next, I don't know how many years. So, you know, are those conversations being fruitful, productive?
Yeah, so I've been a member of the One Herefordshire Partnership now since 2020, and as you say, we've obviously got the early adopter status for neighbourhood health, so both David and I are wrapped into those conversations. I think with public health, I've been involved in the Joint Strategic Needs Assessment, and that's really helpful to make sure we don't lose the focus on mental health. Talk communities, absolutely, because that is absolutely for us about how do we make sure that those earlier conversations about mental health, for example, would link into the talking therapies pathways. So there's a level of granularity as well as a strategic commitment to wanting to work in partnership with our colleagues, and we've got a track record of doing so.
Chair, can I just round out the length of stay? Just returning to that point then, before we move on to the final element in the table. So just in terms of that kind of rigor processes, there's one other element. It occurs to me we haven't specifically mentioned, which I think is worth mentioning, which is the bed management function. So one of the things that has proved helpful in oversight of out-of-area placements and really driving the length of stay agenda. Sue talked about sort of granularity and you know, having a more real-time understanding of the picture, but it has been enhancing, and additional investment has gone into this. Initially as a trial, but we have just it has just been agreed that this will be embedded and funded for the future. Additional investment has gone into creating a 7-day-a-week mental health bed management function across the 2 counties. So historically, the bed management model in mental health has really been a Monday to Friday 9 to 5 model. So there's been a small bed management team who've had oversight of that during the working week, and they typically, historically, what they've done is they kind of set up the plan for the weekend in advance, and then, you know, gone away over the weekend, come back on Monday. Sometimes, speaking very frankly, that plan has survived contact with reality. Sometimes, by the very nature of you know, the dynamic situation with which mental health colleagues, social work colleagues are wrestling, it hasn't quite. And in those circumstances, what you get is decisions being made perhaps at ward level or by on-call managers who maybe don't have the same level of insight or long-term understanding that the dedicated bed management team have, which are good decisions insofar as they keep people safe, they respond to the immediate need, but they maybe aren't fully balanced with the longer term thinking about, well, where are we going? You know, how do we want to actually use our limited resources over a protracted period of time? So what we've done is we've introduced that mental health bed management function at the weekends as well, and they are the skilled team who can help to make those decisions. Yes, Monday to Sunday now. That's been very, very helpful. On-call managers have found it very helpful as a resource, and I think, you know, the proof is in the pudding. The evidence is that we have reduced inappropriate out-of-area placements, and length of stay, you know, has benefited from that.
And quite rightly, you suggest that Monday to Friday is no good. We have to have Monday to Sunday and 24/7 availability. Obviously, out of hours, there's going to be a different system, but you know, it's still there.
Yeah. So if I just move on now to the final element in the table, which relates to mental health support teams in schools. So again, this is not a service I directly manage. This is headed up by my fellow associate director, Sonia Upton, who's responsible for all of our children and young people's services. The target is to have 2 new teams stood up by the end of the next financial year. That's 65% of the overall plan, and then further expansion over the 2 successive years. We've got new funding confirmed for 26-27 in support of this already, and there are commitments to continue that funding trajectory to meet that eventual 2030-31 ultimate goal. Sonia tells me that recruitment is strong for the current wave of expansion. So she's got no concerns about continuing to meet that trajectory.
So is that being communicated to the local authorities, Children and Young People's Directorate, through Tina Russell, the Director of Service?
The Tina would be aware, because we've turned around and been working on this for a number of years. These services have been around now, oh gosh, probably 6-7 years. So yes, that I think the concern was that it might not expand any further, and that would leave some schools with a gap. But now it's 100%, albeit with a longer tail. Again, this is a workforce that we train up, very similar to talking therapies, but it's a very attractive setting for people. We get a lot of applicants for this, so it's a great new workforce that we didn't have before. So yeah, Tina will be aware strategically, and then obviously we work with the team in terms of making sure that we've got the education setting links, and then we roll that forward. So we do that in partnership.
So does she get feedback on that, or do you, on this service moving forward?
I can take that away and see what, if there's anything further we want to share. There's always learning, and that will be with each education setting. And it could be then that we might think about, is there anything further we'd want to do as we move forward to that 100% expansion? Yeah.
Yeah, because the concern is if you've got a school that's experiencing some concern, that they're not contacting the right department. So, you know, if they are sharing anything, that everybody needs to know about it so that we can,
And these are really interesting because these are mental health practitioners that actually sit in the school.
yeah, which
So,
is brilliant
and
news.
they've worked very much to map the rollout to those schools most in need. But it is great to see that commitment to having full coverage by 2030.
Just very quickly, this trajectory of 65 to 100%, is that uniform across the two counties, or is there a lag? Are we below Worcestershire at the moment? Just where are we in context within the two counties?
We can take that away and come back when we want to be factually inaccurate, but my understanding is no. There's been percentage for both counties, and that's what we've been working towards, but I'd like to get that confirmed, if that's okay.
Yeah, I think you've already identified the differences in numbers for Herefordshire and Worcestershire and other areas. So that information would be welcome by committee members.
Not least of all because obviously I can see there are particular challenges with some of our rural schools, just in terms of the logistics of getting teams out there or staff out there. So it would just be interesting to know where we are at the moment.
Yeah.
Obviously, the target is 100% by 2031, but possibly addressing some of the specific issues that are for in particular some of those rural schools.
No, agreed. That's really helpful. I'll take that away and we'll come back to the committee.
Councillor Thomas.
Going back to what you call inappropriate treatment, are these people basically farmed out to other local authorities, health services, or are they farmed out to private companies?
Councillor, the answer is it can be either another NHS trust in some cases where they have chosen to offer some of their capacity out commercially, or it can be to a private provider in some cases as well, and that will depend on where the capacity is in that moment.
And do we, our health service, provide in Hereford and Worcester, provide the service for other counties?
No, we don't. And it's probably worth just talking again about a little bit about the word inappropriate and what we mean here. So across both counties, for example, we don't have any beds for eating disorders. So if you need an inpatient admission with an eating disorder, you will go out of area, but that's seen as appropriate because we haven't got the beds in county. So this is when, for example, Stonebow and then the services up in Worcestershire on the Elgar site are full and you could be there, but we haven't got capacity. But that's the work we've been doing. We've been really doing very well at keeping that to zero over the last, got to be at least, I think, since June, maybe longer. So yeah, we've got the right capacity at the moment because we're running at zero, but we're not at the point where we're therefore able to offer anything else up. It's what we've got. We're making work for our local population.
The other question was, you're talking about talking therapies. Who conducts these? Are we talking about psychiatrists, psychiatry nurses, or who?
I think I would describe the group of people who deliver these services primarily as therapists, counsellors. So at the lower level, which we call step 2, these will be psychological wellbeing practitioners who have been given a training in primarily cognitive behavioural therapy. That's the main modality that operates at that level, and those will typically be quite short interventions, perhaps 6 or 8, or at the outside edge up to possibly 10 sessions over, you know, a number of successive weeks of, as I say, cognitive behavioural therapy. At the higher level of intervention, so what we call step 3, we have a range of interventions that would normally, some of which one might encounter also in outside the health service in the commercial sphere as, you know, counselling and therapy type interventions. Some of which one might call, yes, talking therapies, counselling for depression, EMDR, things like that, and also higher intensity and more complex interventions based on, again, cognitive behavioural therapy. And those might last slightly longer as interventions, so not so much 6 to 8 sessions, but perhaps 10 to 12 sessions. And in some cases, for some of the most complex interventions, you might be seeing a therapist for up to perhaps 20 sessions or something like that.
And just going back to Councillor Thomas's question regarding out-of-area placements, I think what we need to think about here is that people are being placed in the right place at the right time. So, you know, it's not just because we haven't got the capacity or whatever, it's giving them what they need. Okay. Any other member questions? Councillor Davis.
Are we working currently at full capacity? You've got the numbers there, and I was just wondering whether or not there is any scope, any movement in people. If we have somebody who requires treatment and it would be appropriate to put them into one of our local facilities, then is there a pecking order of, we could use this person has a greater level of need than maybe somebody who's having treatment, and they might be moved somewhere else? I mean, does that juggling take place? Is our capacity full? A couple of questions there.
Yes, this is where you might use your home treatment teams. So they are a really high intensity team that might go in, 4 or 5 times a day. So if we were to have somebody who was being detained under Section 3 of the Mental Health Act and really, obviously, for their own safety, would need to be in a bed, we've got somebody else who was ready to come off the Act and could go home. Those are the judgments the clinical team and the bed management team that David's described are doing every single day. So some of it's home-based capacity, some of it's our step-down rehab. And so, yes, that's exactly what people are doing, is making sure that the person with greatest needs in those more intense, high-intensity beds.
So is our current capacity then full at those at our facilities?
That varies because we will always running at higher occupancy because we don't have a high number of beds, but that turnover is there because that's how we've managed to keep the people going out of area inappropriately at 0.
Okay.
Councillor Tully.
Thank you. So I've got 4 questions. Can I throw them all in now? I'm going to try and keep them as precise as possible. The mental health teams in schools. I know this is a plan, but I'd like to compare that with something, and I've got an awareness of the way that schools manage things at the moment through a lot of different friends and my own experience. What is this compared to? So for those schools that don't have a team or aren't kind of covered at the moment, what happens now, and is any of that outsourced in the way that you talked about the Landau stuff? I encountered at least 4 organisations in the there was like a roadshow of services recently, and I encountered at least 4 organisations doing really amazing things, seemingly in schools. I hadn't really been aware of any of them. And I asked each of them, how much contact do you have with those guys over there? And they're like, oh yeah, sort of, we kind of know what they're doing. So how much of this work is, collaborating with the other people? You're going to get a theme of collaboration. And then you talked about Landau and that they're successful. I wonder how you share those successes. And you also talked about the lag when there's a third party, and I wonder what your perspective is on why then is Landau not just commissioned directly? And this is a thick question, but if there's a middleman and there's a lag, who's benefiting there? I wondered about the connection with reablement. So, I apologise about my lack of understanding of different services, but obviously, people, physical ill health is markedly linked with mental ill health and all of those kinds of things. Something that we've been finding out about is that people want to improve the kind of reablement, the pathways of people's reablement, and I wondered in the work that Gemma Diss has been doing, how much connection is there with the reablement? And you said that there are tensions in the way that sometimes the work that you're doing and the work that the social care are doing. What are the mechanisms that you've got to manage those tensions? So where's the strategy for managing those tensions that plainly do exist? Number 4, again, in terms of engagement with the things that the council does. Talk Community, you said that you do work alongside Talk Community. Where do they appear in the strategy? So where do those kinds of work appear in the strategy that you are sharing with us? That's it. Thank you.
You can see I've just been scribbling away. Shall I take a couple and then ask David to come in on some of the specifics? I think the first one around how does this sit with other resources around the schools is piece really where we're saying, well, neighbourhood health will have to feel different for children and young people. It needs to be wrapped around groups of schools as opposed to necessarily that being GP based. So it is slightly different, I think, that conversation. It's a very live debate. What you will have for the schools that don't have the emotional mental health and wellbeing support in schools programme yet, you will still have CAMS having a linked worker model, and they'll still be going in. So there's something about us understanding who is in that space, because it may look different for schools. Some schools purchase educational psychology, don't they? Others don't. And our links will be, and I think that's the piece I'd like to just pick up really with Tina, where we're talking about neighbourhood health. How do we map out what's already there? And then obviously we know what that looks like then as we move to 100% coverage.
Can I just double check then that it done well, that it successfully, that would then ease the impact on CAMS?
Yes.
Okay, thank you.
Yeah, we have seen that already in the rollout. Yes, the whole point is to really support the school to be more mentally resilient and to have that kind of best start in life. It's quite a different way of working, whereas obviously a lot of the way we've worked with schools traditionally has been a referral singularly into CAMS, for example, whereas this is about saying, can we make this a more mentally healthy place for our children to thrive? And then when you have individual children that are struggling in school, then West can see them, which is the name of that service. And that means then they're not going into CAMS or having to deteriorate to then potentially move into CAMS. So that's why I think the political will to roll these out in full is because the evidence base is really strong, that they're doing some really great work. So I was going to ask David to pick up on the land down and then the reablement links, because I'm less cited on those. But the Talk Communities piece, yeah, absolutely, is the neighbourhood health agenda. So that's there very much at the table with a number of us when we're looking at what are we going to do over the next 5 years in that in that neighbourhood health space. The tensions around partnership are the very real things that we need to be talking about, because it's easy to say we're all going to work as one multi-agency team, but actually it's really difficult when it gets into the IT systems, the data sharing, the demand management, who does what, understanding that, governance, regulation. So all of that has to be worked through, I think, for us to really realise that ambition, as opposed to just sort of think it's going to be easy, because I think the goodwill's there, and I think we've got some brilliant component parts in Herefordshire, but then we're going to have to work out how we unlock some of the benefits for our staff to work differently.
So is there a stumbling block here between the local authority and schools and mental health services? Is there something we need to be aware of that we can try and support?
No, I don't think particularly. I just think it's just those mechanisms. Are we getting the right children to the right services at the right time? And often in my experience, we end up defaulting to CAMS, and actually then CAMS becomes, basically gathers a waiting list. And that's where we serve our children really badly. If you're really poorly and you need to be seeing CAMS, we need to see you in a timely fashion. So I always get a little concerned then when I hear people almost translating mental health support for children as CAMS. It's got to be a broader conversation. We need to keep it as upstream as possible. And then when you need timely access to CAMS, you can get it.
Can you just remind committee members what CAMS stands
Child and
for?
Adolescent Mental Health Services. So our services really for our most poorly children. We've got some other more quite specific services. So early intervention in psychosis is a 14 to 35 service for children experiencing their first episode of psychosis. The evidence-based get children into those sort of support structures early. You can really make a lifetime impact. So those aren't the services where we want to be holding children up in terms of access. So the school environment becomes even more important in terms of trying to make sure that that offer really works, and we need to do that in collaboration.
Sue, can I it's just a thought has just occurred to me. Are we talking only here about local authority maintained schools, or are we talking about all schools? And if it's all schools, so, but is there any difference in the approach that you have to take with academies or MATs?
I don't think I've got the detail on that in terms of being able to say whether culturally it's different. I've certainly had nothing raised to me other than gratitude from the schools that they've got this service available to them. So nobody's come back and said, oh, actually, this has been a bit of a challenge. In fact, I think the reverse is true. But it's I'm sure it varies a little bit in terms of how you tailor the approach school by school.
Just one question I've had raised to me is regarding the 2-hour response time in urgent care being delivered. Is that, I assume it is, that's your department only? This doesn't relate to anybody who goes through Wye Valley Trust?
That response in the table is actually for community services. So here it's for Wye Valley. Yes, that's very much in relation to Worcestershire. So we have other metrics which we look at locally. For example, people with mental health concern or illness ending up in A&E. And actually, again, that's quite low here, and we've got a pretty good turnaround. That links again to getting those beds available or making sure we've got the liaison team to support people to go home safely. So there's a little bit of urgent care for us, but it sits more in that space.
Thank you. That's a lot clearer. Thanks. Any other? Yeah. Sorry. Back to Councillor Tully.
So, I'll speak. I might need a bit of help on the reopening, or we might need to circle back to that one. But on the sort of the contracting question, which relates specifically to the IPS service with Landau. Firstly, there has been a degree of delay. I don't want to make too much of that. So I think, as I said, that the overall target for the services here is 217. I'm expecting them to alight probably within 10% of that. So it's not a. It's obviously it's a shortfall in performance, which is regrettable, but it's not it's not a huge one. And the delay, I think, in significant part relates to the initial agreement of the funding rather than the kind of the operationalisation of it. So in terms of our contract with Landau, it's not so much the fact that we subcontract with them or that we otherwise would be doing the service ourselves. It's more that funding, it took a while to agree that funding, at the sort of the headline level. But on that kind of question of does it make sense to be subcontracting these services, what I would say is we've worked with Landau for many years. We do that in a situation where in Worcestershire we do actually provide these services ourselves. So we have these different models of delivery for historical reasons, like that. Those have evolved. This goes back to before my time. Both of those services are actually quite closely matched in terms of their external validation position. So we have in IPS services, we have something called fidelity scores, which are externally adjudicated kind of performance scores, service delivery scores, what happens every well, I don't know, 2-3 years probably on average, so you get the external subject matter experts, IPS grow, who sort of validate and benchmark these services nationally, come in, they look at everything the service is doing, and they say, yes, that's good, that could use a bit of work, and they give you a score at the end of it and a rating. Both our Worcestershire and our Herefordshire services are scored in the good banding on their fidelity scores. And my experience of these two services is I don't really perceive them as being different in any meaningful sense. The Landau team are very well integrated into the neighbourhood mental health service within which they deliver their service, and they are really part of the wider team. So currently, I wouldn't want to change it, and that's not because I see the model of delivery as being better either. It's just it's just where we've alighted. I think it's fit for purpose. In fact, the evidence is it's fit for purpose. We might need to circle back around on the rehab question, if that's okay.
That's absolutely brilliant. If you could explain to me what circling back around means, and then I'm very happy to circle back around with you at any point.
Councillor, forgive me. Can we repeat the question?
Oh, I'm glad I double checked, because I thought you meant I'll let you know later. So after the admission, so the times when, loads of this is not to do with admission, I totally understand it. After there has been an admission, and then talking about when people leave and some of the issues around that, and you mentioned that Gemma Diss has been doing a lot to shift things so that numbers of out of county, etc. But the pathways of reablement, how much interaction? Again, it's just one question all the time. It's about connection, and then what mechanisms you've got to manage the fact that there are tensions there between the bed availability and the availability of teams and all of that. So how much of interaction is there with the pathways of reablement?
Yeah, probably less with reablement, more so within our own home treatment services. And that's not to say you don't get silos within silos, even within one organisation, within teams handing off. Hence why I was saying earlier, we really had to get the bed management team working with the home treatment team to make sure that you've got that timely discharge. Crisis teams have to be involved in that as well, because they're often a key point of admission and therefore part of making sure that somebody can step down safely. So a lot of it is the trust internal service configuration that we've been working through. You will always have adult social care involved, where the social worker, and they often come in and they're part of that multidisciplinary team. I think in Herefordshire, actually, there's always been a really good problem-solving approach around trying to make sure that we've got people in the right setting, so the chair's point earlier. So you might recall there was a change in policy with the police some years ago about their response to mental health call-outs. And we've got a multi-agency group, and each time it looks like, for example, we might have asked for the police to respond and it wasn't appropriate, or we felt we needed the police to respond and they didn't, and that wasn't appropriate. There's just a learning review and social care around that table. So I think we've got a mechanism where people actually doing the job have got really good connections, and they go around that loop when things haven't gone so well to try and resolve tensions, make recommendations where policies might not be working. I think it's fair to say with the demand into some of these spaces, that's a real live conversation. But I think my experience is everyone always says, right, sleeves rolled up, let's try and do the right thing. And how then are we going to make sure we learn and change things if needed? Yeah.
Chair, could I just add to that?
Oh, I thought.
Thank you, Chair, and thank you, Councillor. It's maybe just also worth mentioning, because I think it does speak to that picture that Sue is painting, mentioning the neighbourhood health agenda, which I think is mentioned in the document that's been shared. So I've been working with colleagues from the County Council, from Wye Valley, tours from the various partners in our sort of overall health and social care delivery in Herefordshire on this Vanguard neighbourhood health programme of work. And although it's not, the initial work is not really speaking to those patients typically who are or will be going in and out of mental health inpatient settings, much more likely to be going into acute physical healthcare settings. It is precisely this sort of collaborative model that we are exploring. So the initial piece of work is going to focus on a small cohort of patients, typically frail and elderly, typically with a number of co-occurring comorbid health conditions, long-term conditions, typically with a history of acute admissions, and looking at between ourselves, between county council colleagues, reablement, social care, with Y Valley, with primary care, what can we do to, as a kind of a multidisciplinary team, to look as holistically as possible at the needs of this, of this cohort and these individuals at an individual patient and human level, to keep them wherever possible and appropriate out of hospital settings, keep them in their homes, keep them safe and well together. So that's a piece of work we're really just embarking on now. But I think it's the kind of the logical conclusion of what, Sue, what you were describing, and I think it's a really positive development.
And I think the council's county plan absolutely supports that comment. Mental health has been identified as one of the priorities of this authority now. So, yeah, we will support as much as we can when we can. Any other questions from members? Oh, there's one.
On your list.
Oh, sorry, it's under the paper. Councillor Tillett.
Okay, a slightly different area of questioning. I don't know, actually, Henry, if page 4 of the Trust strategy, or Daniel, can be brought up. If I can just turn you back to the original strategy. I've got a sort of a nitpicky point and then a main point.
I need a minute or two just to get the
Oh,
strategy.
don't worry, I'm sure it's the map. It's the map.
Yeah.
So here's my nitpicky point. In Herefordshire, we have a city and we have 5 market towns, of which we are enormously proud. Where's Kington on that map? Exactly. What have the good citizens of Kington done to upset you? So there's my nitpicky point, but it's just the precursor to a much broader point. Even with Kington accurately on that map, there is that great swathe of open space to the north, the west and the southwest. And to a certain extent, some of these issues apply to Worcestershire as well, but they are particularly pertinent to the huge rurality of Herefordshire, which we as a council, understand. The government doesn't, but we do, of the huge challenges of trying to deliver services. And it really concerns me across the health service, and of course it's riddled throughout your document of this, targeting services closer to home to reduce travel. People are being seen nearer at home or at home. It's a huge, huge challenge. I mentioned it earlier in terms of obviously our rural schools, but obviously it's is it a third of our residents live out in the countryside, a third live in the city, a third live in the market towns, but there's a third of our residents live out in some really remote places. How are you going to deliver these sort of neighbourhood at-home services to some of our most remote patients, some of whom, of course, may be, if anything, very slightly more inclined to have mental health issues anyway?
And there's no easy answers to this, is there really? I think this is where we need to collaborate to think, how are we using our resources to best effect? It is a real challenge. We've got some very small teams covering some very large geographical patches, and some of our teams you can't carve up in lots of primary care networks because they're just not big enough. So I think that is the point that we've been trying to work through with the neighbourhood health. Could we start with a proof of concept around some of those frail elderly people who are coming into Wye Valley? And I think the ask predominantly of us is really more around dementia at this stage. Can we liaison into some of those teams that sit in general practice to put that specialist skills in, so then we're not basically admitting people into all the wrong spaces and places? So I think the other piece that I'd probably throw out there is there's quite a lot of reliance in the 10-year plan on that switch to digital. That's a challenge out here too. So I think the only way we've got to keep on having conversations about how do we use the resources we've got, but we use them geographically as opposed to organisationally, and that's quite a different way of working and thinking, isn't it? So I don't have any, and I'd like to apologise to the people of Kington. You're right. The minute I looked there, yeah. So yeah, I mean, David, you've got real life examples where we've tried to map out community mental health services into some of these spaces, and you just spread them very thinly. It's great to see investment into some of our services. That gives us more organisational resilience, but we might have to organise them differently as well to enable them to speak to the geography.
Okay, thank you. So I'm just going to really go back round now and step back a few comments ago where you were talking about staff turnover reducing and staff experience. And I just wonder, given the CQC comment on organisational culture and leadership cohesion, how has the strategy allowed you to build a more open culture where staff feel supported and safe to raise concerns?
Yeah, very much something I wanted to pick up as well, actually, is that there's other parts of the strategy which we haven't really walked through in more detail around our expectations around reducing temporary staffing, reducing sickness. Obviously, we've got to manage our efficiency programme, a whole wealth of stuff on our estates and those digital solutions. But everything's come down over the last 2 years to being culture. So we have done huge amounts of work around a compassionate, inclusive culture. I talked earlier about the leadership changes. We are seeing people now in our pulse surveys, which we do every 3 months, saying they are now much happier with their I suppose, with the way in which they feel they can raise concerns at work. Certainly, we've got a very different way now of supporting people to raise concerns. So we've moved from a more traditional HR structure into something with a resolution focus, earlier mediation, less move to formal grievance. So there's been some structural changes we've made. We had some external support come in to roll out a culture programme across the whole organisation. We've carried on with that internally now with one of our lead psychologists who works in my team to just continue to embed that. That's been evaluated really well. The green shoots that we're seeing are around the areas that we wanted to see it in. So would I recommend my organisation as a place to work is a really, really key metric, and we're starting to see green shoots. Certainly when we get the feedback on the National Staff Survey, which we are not able really to say very much about at this stage because until it's published in March, that'll be a time then to basically give you further information about where some of those shifts have happened. But our internal metrics are showing that people believe there is a more open culture. They recognise how to raise concerns. They would feel more comfortable. And we've got the Freedom to Speak Up Guardian. We've got culture champions. We've got a very open space on our intranet where people can say things anonymously if that feels safer for them. And the big piece for me has always been about leadership and line management. So if we can get leaders feeling confident to recognise things that are looking tricky or might not be as we want them to be, how do they get into those spaces early and facilitate different conversations, and to make sure that where possible we're learning and we're being curious rather than jumping into formal processes to resolve issues. So yeah, a real step change over the last 18 months, but it's a bit fourth bridge, I think, we've just got to keep on working. And then we're doing a piece of work at the moment where we're trying to triangulate some of those pockets of sickness with potentially our incident data, with some of those areas where we might get more concerns, to just target our resources in sooner to teams that might be struggling. I think I just asked David to come in, but you know, the demand into some of our services and the acuity feels very different to 5 years ago. So how we're making sure that our staff wellbeing is really protected and they get a really good offer, they know what they can receive, how to support them, because we want people to be able to come to work well and do a really good job, and in the context of really, really quite challenging circumstances.
And I think the importance of that workforce akins to the midwifery service, because midwives and psychiatric nurses can all retire at the age of 55. So it just shows that, you know, those two areas of work are appreciated and experienced by the NHS as being quite a challenging workforce. Just on the same thing, I will go to Rebecca in a second. What strategic actions will improve staff training? Because I know there was at one point a concern about competencies, etc. So we got the mandatory and the Mental Health Act training. And how do you monitor the ongoing commitment and competencies? If you want to take that one away, because it's a bit of a like, oh.
I mean, just to say that mandatory training is regularly tracked and comes to our integrated governance route and comes into people and culture committee. So the Mental Health Act training, we've got a team that are looking over that, but it might be one to take away to come back with a bit more detail, Herefordshire specific for you.
Thank you. And I'm just going to go circle around. It's an NHS language. Thinking.
At least you're going to repeat yourself. We don't want you repeating yourself.
You mentioned surveys with staff, and I just wondered if terminology comes out of that from the parents' feedback as well, because on page 14 it says try not to forget kids who have moms and dads, not just moms. And I'm like, is this an American feedback person, or is this just a term that we're using now? I've never called my mum mom, but people might do.
It's a direct lift from our care opinion platform, so whoever's put it in, that they're clearly using that language, yeah.
And apparently from Daniel, he says that it is a Birmingham thing, so I stand corrected. Rebecca, Councillor Tully.
You can call me Rebecca anytime. All of you can. You mentioned a plateau in demand for, I think, IPS and talking therapy, and I proudly bring a lack of understanding of jargon to this meeting. I think that's what I'm meant to do. You mentioned a plateau in demand, or even a decline, and I'm not sure if it was one or both of those things. And my understanding of the ins and the outs, and adult social care being a huge worry for the increase in demand in this county. Just help me understand that. It could just be that I'm misunderstanding the kinds of services we're talking about.
Thank you, Councillor. So I don't think I quite said there was a plateau in demand, but it was in response to another question. So we have an expansion trajectory for both of those services, for talking therapies and for individual placement services. That expansion trajectory runs out over the next 3 years or so. It slows over that time after a period of rapid expansion. What happens after that is not clear. I think I mentioned not having a crystal ball. But I think it is possible that at that point the expansion could either reduce further or even cease, or there might even be a decline over time, depending on what demography does as well, depending on what happens to the size of the population we are expected to be serving over that time. So I'm not necessarily making any predictions about what demand will do. I'm just talking about the expansion trajectory. I don't have a crystal ball. I don't know whether that makes sense.
I totally understand that. And I think no services have a crystal ball, and nobody, I know no services have a crystal ball. I'm just aware of the housing targets, and I'm aware of people's expectations in terms of adult social care demand. So I don't quite understand why without a crystal ball, why any service around this would be saying we think it might just tail off a little bit, because it feels like it's not going in that direction for anybody. And I guess that's where my challenge is.
I mean, I think I'm probably in wait to see mode.
I suppose the other piece, without getting too technical about it, is talking therapies has got a very clear criteria, so it's not for everybody. And I think the trick is, how do we get agile to respond to different need? So it might be you do get to a point where talking therapies is something which you may have enough of, but that won't mean you're meeting the demand, because the demand's presenting differently. It's very difficult to describe quite how criteria-led some NHS services are, and that's not of our making. Those are some of the national evidence base, but it doesn't give us the flex to then go, oh, this isn't the right door for a whole group of people. GPs are seeing X, Y, Z, they're not right for talking therapy. So those are some of the conversations we're having, which is demand's changing, how do we meet it? Because talking therapy, it isn't for everybody.
Councillor Davies.
Thank you, Chair. If I can just move slightly back to the mental health teams in schools, there's already provision for pastoral care and SEN care in local schools. So is this going to support that provision? Is it going to complement it? Or is it going to be something totally separate in the teams coming into the schools? Because that will probably, there'll be an element of crossover there between what we're hoping to provide and what's being provided already.
Yeah, and it's a really good point, because I think we've recently done an audit again of the levels of ADHD and autism in our CAMS caseload, and we're talking upwards now of 40%. So we have got to work with Senco, and we've got to be able to make sure that these things are about helping the school manage those children to be able to stay and thrive in education, rather than referring to each other. So the mental health support team in schools is workers who actually come in, stay in the school, and they really will work with those other partners to make sure that they're wrapping around the child. And a lot of it then is helping the school to work out how would they then feel better equipped to manage some of that lower level mental health. I don't like that expression, but that's sort of, I think, the terminology that everybody has come to expect. So it's very much an upskilling for the teachers. It's some of that individual support, but it's done earlier, and then it's working out how do we bring together different competencies that are in the school to meet individual child's needs. So that's the beauty of it being in the school, as opposed to them having to refer out and then somebody coming in, is they're aligned to that school and know the processes.
Would that be done through all children's ages, so across primary schools, secondary schools, sixth form colleges?
At the moment, this is secondary schools, and it doesn't, so that's it exclusively. We have got other initiatives that are going into primary schools, which we're working through in terms of that interface with early presentations of autism, and then what we need to bring in from mental health.
Any other member questions? Nope, doesn't look like it. Okay, so just really thanking you both for the information you provided today. I think the committee now needs to ask our officer if we've got any recommendations from our debate this morning.
Yes, we do, Chair. Just give me a moment, and I will put them on the screen for you.
I'd just like to add that the committee recognises the work underway, but remains keen to see clear evidence of sustained improvement, particularly in relation to safety, workforce stability and governance. So we will look at possible recommendations if we agree with these.
I'll read these out for the purposes of the camera. I've had two draft recommendations come through during the course of the discussion. The first one is that the Trust provides a committee with an annual update of its strategic plans, priorities, sorry, I'll have to just reword that slightly there, including workforce capacity, recruitment and retention, training compliance, staff survey results, freedom to speak activity, with any actions taken where performance was identified as requiring improvement. I just want a caveat just in the discussion that was happening in the background whilst this was on. I think there's a feeling that you might well be reporting this somewhere anyway, so we're more than happy to sort of fit in with that so you're not producing bespoke reports for us. The second recommendation being that we provide the committee with the findings of the National Workforce Service when available.
And I think that was coming in March, I think you said, Sue. Is that right?
Can I just clarify what that second point, just to say that that first group, I can get hold of that because that all reports into our standard committees. It's just a matter of extracting the elements that you've listed there. The National Workforce, we've
Sorry.
got our...
Survey. Sorry, I
National Survey.
Yeah, my apologies.
Yes, that embargo lifts on the 13th of March.
Okay, any other comments? No, okay, so I think we have noted the purpose of this agenda item and really qualified it quite well. We have had a good discussion, debate, and have lots of reassurance, I hope committee members feel.
Chair, can I just confirm, can we just take the tiniest of votes on the on the recommendations, please, as read out? I'll just share them on the screen again. And in fact, I know this sounds pedantic, and you might well be groaning, but I think it's probably vital that I read them a second time out, just for the sake of completion before you vote on them. My apologies.
I think one of us mentioned about Herefordshire specific on that second point. So before you share the screen, in our back chat, you had a really lovely sentence. Could you just
That's
put
a
that
very
one
good
in?
point, actually. Just talk amongst yourselves for a couple of minutes, please. I'm just going to need a...
So are you circling around?
Oh, don't.
I just realised we have to admit that we've got a channel, a hidden channel.
My laptop. Hold on. Let's just...
Sorry, we should have a musical interlude here while Daniel sorts his laptop out.
There we go. I'm nearly ready.
But again, I would just like to thank you both for coming and sharing everything with committee members. It's been really insightful. And he's ready.
Okay. Once again, for those at home, the recommendations are as follows. 1, that the Trust provides the committee with an annual update of its strategic priorities, including workforce capacity, recruitment and retention, training compliance, staff survey results, and freedom to speak up activity, with any actions taken where performance was identified as requiring improvement. The second recommendation being that the Trust provide the committee with the findings of the National Workforce Survey when available, with detail pertaining to Herefordshire where possible.
That sounds like it's a plan. So
You have to vote.
can we have a vote on that?
And correct the spelling of available.
Okay.
Old teachers never die.
There's a bit of a typo going on there, but it's corrected.
There we go.
So are we all in favour of those recommendations?
Great stuff.
Yeah, that's unanimous. So that's covered. Thank you. Yeah, again, thank you very much. And you're welcome to stay and listen to our work programme if you want. But I'm sure your journeys are really
and
more
thank you,
important.
because it's really great as well that you're asking so many questions around how you can help and support and collaborate. It just feels like that's the conversation we should be having. So thanks for giving us the opportunity to come and update you.
Yeah, we love a conversation like this. It's really helpful to us. Thanks. Okay, so I think we could ask for an adjournment now. It is I'd like to welcome everyone back to the meeting following that short adjournment. So we are now on agenda item 8, which is the work programme for 25-26 and 26-27. So I'm going to turn to Daniel to just address this one.
Thank you very much, Chair. You have a busy work programme ahead for the year ahead. We have our next meeting on the 27th of April where you've asked to look at neighbourhood health and how we shape neighbourhood health. I suspect that might be Sue Harris back with us at that meeting, but obviously we'd have to speak to Wye Valley Trust as well with regards to that. I think you also wanted to look at how things are happening in Worcestershire, so we'll drag out some of the Worcestershire Council papers for you for reference, as well as speaking with tourists. As well, I think you might recall the CQ gave an inspection of our social care services last year, and we're still waiting on the findings of that inspection and the report from that. So we placed that into the diary for the 27th of April. Again, that could slip and slip and slip, so do keep in mind that that actually might not happen in April. We can't do anything until they publish it, so our hands are tied. Nonetheless, in April, we do intend to provide a briefing for you on the Herefordshire Safeguarding Adults Board annual report. There might well be topics from that you choose to bring back to the committee, but that will just be very much a briefing on the work of the committee and their priorities going forward. July, you'll be looking at the joint strategic needs assessment and the health and wellbeing strategy that stems from that joint strategic needs assessment. That's quite a complex topic and a big topic, so if you wish I can arrange some briefings with Zoe Clifford and with with Jessica Carrier on the research that's being undertaken for the assessment and for the health and wellbeing plan that stems from that. I think that would be really good rather than bringing it to the committee, otherwise you're just going to get a wall of documentation and detail like that, which is quite hard to sort of plough through. Okay.
So are members agreeing that we can do that rather than bring everything? Yep. Mm-hmm. Yep.
Okay.
So that's
and then finally in September you'll be looking at Right Care, Right Place, which you've committed to look at again following West Mercia Police's attendance at this committee early last year. And then we'll be looking as well at the Q2 Better Care Fund outcomes, if that's available. And then finally, in September, we should have a draft report and recommendations from the Meeting the Demand for Adult Social Care Task and Finish Group.
looking at the Task and Finish group, Councillor Tully is chairing that. Would you like to make any comments?
Yeah. So Henry and I have met with a number of people, spanning talk community, adult social care themselves, research team, someone external who's got experience in 2 other areas, and we'll be ready to review what's been talked about and bring some thoughts and some findings to the review meeting. And yeah, there's about 3 themes coming out as well. So there are linked themes from pretty much every conversation, which I think has been really positive. And I think that this conversation today has also been really useful.
Thank you. So can I just ask, Daniel, is there a list somewhere of the Task and Finish group members, especially for this one, because I'm not sure who's on it now?
There are, Chair. I think I defer to my colleague Henry Merrickx-Murgatroyd, who is leading on this on a day-to-day basis. He'll have a clearer sense of who's in the committee. Forgive me, I don't know all the names.
Yes, Chair. The members of the Task and Finish group are as follows: Councillors Andrews, Tully, yourself, Councillor Crockett, Thomas, and Councillor Tillett. Yes, you're a member of the Task and Finish group. You're in the channel. And
that, but
we've got our first review group
I
meeting
think
at
that
the end of this.
perhaps is not correct.
No,
is
I
that?
don't think it's
Yeah,
correct at
yeah.
all.
And I do believe Councillor
Harvey,
Harvey
yes.
had an interest in it at the initial stages. So
Yes, Councillor Harvey is also in the group. Yes.
right,
Yes.
okay.
Apologies for that.
Yeah.
Yeah.
Okay. Councillor Tully.
I understand that Councillor Bartlett is also.
I'm
On
just
the-
looking at the channel on Teams with the. Sorry, Chair. Can I just?
I'm going to have a quick look at the email thread because
Yeah.
I think it might be a little bit.
So what I'd like to ask is that Henry, you get the list of members who are on that task unfinished group and add it to this document.
Okay,
please.
that's fine. Can I just correct the group? I've gone to the our meeting invite in the calendar. So it's Councillors Andrews, Crockett, Tillett, Thomas, Tully, Bartlett, and Harvey.
I mean, specifically, when this was raised, I said I wasn't able to commit to it. I appreciate I'm in the chat group, but I just assumed that was for your information rather than as a member of the group. And I didn't think, Chair, that you were a part of it either.
Yeah, I have always acknowledged I would be part of it, but I don't think we need to recruit anybody else. I think we'll have suffice. Is that okay, Councillor Tudd?
Yeah, and please, feel free to step back or maintain not having stepped forward.
All right, yeah, just to confirm then, we are having our review meeting at the end of the month, and anyone who doesn't want to partake as part of the task and finish group, yeah, feel free not to attend. Okay, thank you.
So that's the Appendix 1 of the work programme. Appendix 2 is regarding the recommendations that we've had ongoing, and I think they're all up to date. So there was just one with numbers now involved, I've written here. So is there something there that I need to ask you about? Let me just have a double check. Anybody got any thoughts on those recommendations on that appendix? No, it's not there.
It's Appendix 2, Chair,
3.
for the recommendations.
Appendix 2 recommendations, is it?
Yeah.
Oh yeah, there we are. So accepted, going down the list. Okay, so there's nothing outstanding there. Appendix 3 is the Herefordshire Council forward plan, and I think the only thing of note on that one is that the Community Wellbeing Directorate have 5 items on there. If there's anything on those five items that anybody thinks we should be adding to our work programme, do you want? Yeah.
Chair, one thing I picked up in the discussion earlier was David from the Trust talking about the challenges, particularly around housing and the re-enablement or the discharge of their patients. And I know this is a topic that all local authorities and health trusts grapple with. It's a difficult one to get right. It's because of the availability of housing and the nature of the people that they are working with. And I do wonder whether this committee might want to explore that, not necessarily bring it back to a committee, but whether they might want to explore that and satisfy themselves that things are working as well as they can be here in terms of that partnership.
Councillor Tully.
It was something that I decided that I'd speak to Henry about in terms of asking David if he'd share some of the work that they're doing with the Task and Finish group. So if that feels enough, I'm definitely going to make contact with him as part of that, and obviously we'll bring that back in terms of the review of the Task and Finish.
that strikes me as there's obviously it's your decision, Chair, and your committee chair, but that strikes me as a thoroughly reasonable way of going about that.
Is everybody in agreement with that?
Yes.
Not just reason.
Yeah. Perfect. So that is unanimous that we have got those 3 agenda items signed off. Thank you very much. Okay, so I think that concludes the business for today. I'd like to thank everybody for their attendance and their input, and I'd like to say that this meeting is now closed.